The following podcast is part of a certified educational activity titled The Multiple Myeloma Workshop, Exploring the Convergence of Novel Therapeutic Platforms, Cell Therapy, and ASCT. Access the entire activity and complete the post-test at peerview.com/ATX860. Downloadable slides and practice aids are also available.
Hello and welcome to this program entitled The Multiple Myeloma Workshop, Exploring the Convergence of Novel Therapeutic Platforms, Cell Therapy, and ASCT. My name is Dr. Bob Orlowski and I'm at the MD Anderson Cancer Center in Houston, and it's a great pleasure to welcome my wonderful colleague Dr. Nina Shah from the University of California, San Francisco. Here's a little bit of an agenda that we will go over. This is a workshop session on the evidence supporting modern therapy with autologous stem cell transplant in myeloma, and we're going to cover upfront treatment choices in newly diagnosed myeloma, including triplets, quadruplets, and what to do about maintenance after transplant. And also we're going to cover new therapeutic platforms and cellular therapies, as well as some of the new exciting bispecifics in the relapsed and refractory multiple myeloma setting. I'll start off with a presentation entitled Making Upfront Treatment Choices for Transplant-Eligible Patients with Newly Diagnosed Multiple Myeloma, where I'll review some of the latest evidence, and we'll have great opportunities for an interaction with Dr. Shah as well. One place that we could start are the current NCCN guidelines for initial therapy in transplant-eligible patients with myeloma, and these have been updated as of 2021 already. You probably know that the preferred regimen is bortezomib, lenalidomide, and dexamethasone, or VRd, and this is a Category 1 recommendation based on the SWOG SO777 study that showed RVd was superior to RD in both transplant-eligible as well as ineligible patients. Probably other regimens that you may use on occasion include bortezomib with cyclophosphamide and dexamethasone, carfilzomib with lenalidomide and dexamethasone, and also bortezomib with thalidomide and dexamethasone. One thing that we'll be covering includes the assessment of MRD, or minimal residual disease, and this has now also been included in the NCCN guidelines, especially in the follow-up post-autologous stem cell transplant. I think you're probably already very familiar with the routine follow-up and surveillance, which include, of course, measurements of the monoclonal protein as well as free light chains, in addition to other hematologic and chemistry profiles. We do recommend some kind of advanced imaging, and that could be with whole body low dose CT, whole body MRI, or potentially PET CT, as well as bone marrow aspiration and biopsy. But now you can consider MRD assessment predominantly for prognostication. We, of course, know that if you're MRD, those patients will have a better outcome if they're negative than if they're MRD positive. And you have a couple of ways that you can do this. The next generation sequencing diagnostic assay known as clonoSEQ is now FDA cleared for detection and monitoring of MRD in bone marrow samples. It's typically helpful to have had a baseline sample obtained prior to the sample done after transplantation, but this uses DNA sequencing and does require at least 1 million cells typically, although higher numbers can get you improved sensitivity. Triplets and quadruplets are now some of the regimens that are available for newly diagnosed patients with myeloma. One of the questions is, what is the best triplet? And we did recently have an update of the Forte trial, and you probably remember that this was for transplant-eligible patients and randomized them either to KCD or carfilzomib cyclophosphamide and dex, and there were 2 arms with KRD or car-len-dex. All patients then got mobilized As you can see from the slide, 2 of the groups got a single autologous transplant, and one of the KRD arms went on to get additional consolidation with KRD only. Then again, they got consolidation with additional cycles of either KCD or KRD. And then there was a second randomization that looked at len single agent versus carfilzomib plus lenalidomide as a maintenance. After the first randomization, we know that patients who got KRD and a transplant, as you can see, had the best progression-free survival, and that was better than patients who got KRD alone. And actually the group that had the most inferior PFS were patients that got KCD and stem cell transplant. And I think these data certainly show that a better induction followed by transplant is the current standard of care. We also showed data from the second randomization, which looked at len versus len with carfilzomib. And here, KR maintenance significantly prolonged the progression-free survival, and there was no increase in discontinuation due to toxicity. And so this gives us a rationale to do a combo maintenance with an IMiD and a proteasome inhibitor. Another update that we recently received, this was at the virtual ASH in 2020, was from the French arm of the IFM 2009 trial. And you probably remember that this randomized patients after initial RVD induction to either continue on with RVD and have stem cells collected but have transplant only at time of first progression, while the other arm got an early transplant followed by RVD consolidation, and then both groups had R maintenance. Here you can see that the group that got RVD followed by transplant had a better progression-free survival than was the case for patients that got just RVD alone. RVD before and after high-dose melphalan transplant, followed by 1 year of len maintenance, was associated with a longer progression-free survival, again, a 30% reduction in risk of progression or death, and there was no increase in second primary malignancies. And so, according to the investigators in Europe, frontline transplant remained their first choice for newly diagnosed myeloma. And after almost 8 years of follow-up, more than 60% of patients were alive in either arm, but more patients had achieved MRD negativity if they got early autologous stem cell transplant. In terms of using quadruplets versus triplets, one of the trials that really allowed us to look at this was the phase 3 Cassiopeia trial, where they looked at VTd as the control arm and Dara VTd as the experimental arm. And I'm sure you know that the Dara VTd group did better. Because VTd is not the most popular regimen in the US, and either VRD or RVD, depending on how you want to call it, is probably the best data set that we have so far is the randomized phase 2 Griffin trial that looked at RVD versus RVD plus daratumumab, and that's outlined in this slide here. Both groups went on to stem cell transplant. Then they got 2 cycles of consolidation with either RVD or Dara RVD, and then maintenance was given with R maintenance for the RVD group and Dara-R maintenance for the Dara-RVD group. Here you can see the responses, and I think there's 2 important take-home messages here. First of all, in both of the regimens, there was an improvement in the depth of response as people went from induction to transplant to consolidation and then maintenance. Also importantly, if you had daratumumab involved, there was a deeper response quality at almost all of the interim analysis time points, and it does really support adding Dara in this setting. And here are updated MRD response and progression-free survival data. You can see on the left that MRD was improved in the group that got dara-RVD substantially, and this did seem to start to translate, especially at 24 months and later, into a better progression-free survival rate. From my perspective, the take-homes on primary therapy in stem cell transplant include, first of all, that induction matters. Some of you may remember from years ago, it seemed that transplant made a difference no matter what induction regimen was given. But now we have evidence that a better induction does result in a better outcome after stem cell transplant. So it does matter what frontline therapy you give. Also, transplant continues to matter because despite the fact that we have better induction therapy, transplant adds a benefit. I think we could debate as to whether patients, for example, who maybe achieve MRD negativity with induction alone, do they still benefit from transplant? And I think that's an open question, but at least until we have that answered, I would still argue that transplant is the standard of care. At least in some settings, 4 drugs look like they will be better than 3 drugs, but which 4-drug regimen is best still needs to be studied. And I think the other area where we need help is what should we do in high-risk disease? Outcomes have improved for high-risk patients with these novel regimens, but high-risk patients still don't do as well as standard-risk patients, so we clearly need to do better. And in terms of making choices, in terms of a triplet, my feeling is that if available, a triplet is definitely the minimum standard of care, and that's true for transplant eligible as well as ineligible patients. Where available, RVD should be the standard of care and probably the backbone onto which other agents should be given. Should we ever consider a quadruplet? One possibility, and these are all hypotheses, are if you have a patient with a high disease burden, it's often more difficult to get them into a high quality remission with a triplet, and maybe a 4-drug regimen is best. Other possibilities include molecularly high-risk disease, although what is the best partner there for RVD is not yet clear. And we could do this in a response-adapted fashion where if people are not achieving a rapid cytoreduction, say after 1 or 2 cycles with a triplet, we could add a quadruplet. Dr. Shah, what are your thoughts about triplets versus quadruplets in the frontline setting?
Yeah, thank you so much for having me today. I think this is not yet answered, and although we have really convincing response data from the Griffin trial, we still want to have a little bit more PFS follow-up to see if this yields a significant PFS difference between the 2 arms, understanding that the original trial was a randomized phase 2, and the primary endpoint there was stringent complete response after consolidation therapy to see if there was a difference between the 2. Now, of course, we do think that depth of response usually correlates with length of response. So I think so far the dara-RVD is outweighing the RVD, but I feel like we need a little bit more information before jumping the gun just yet. What do you think?
I agree certainly that we need more information. I think that in a population where quadruplets are possible, I do think that taking somebody with a high disease burden where I find it's more difficult to get them into a high quality response, let's say people, and I'm pulling a number out of a hat really because we don't have data, but if you've got somebody with 75% bone marrow involvement and a monoclonal protein of 5, those are going to be more difficult to get into a CR than if you're starting off with 25% involvement and a 2-gram monoclonal protein. And I think that if we could get a quadruplet approved, I would probably use it in that higher disease burden setting. And then in patients with high-risk disease, although we don't have randomized studies showing that for a purely high-risk population, adding daratumumab, for example, is of benefit. And in fact, we did see data recently published from the SWOG trial, which looked at RVD plus minus ELO. And unfortunately, elotuzumab did not improve outcomes. But nonetheless, because of the Griffin data, for example, that you saw, I think any 4-drug regimen that gives you a greater MRD negativity is probably going to benefit both standard as well as high risk. So I do try, where possible, to use a quadruplet in high risk patients and in high disease burden patients.
Yeah, I think one of the things that we're going to see now also is going to be, okay, if you have, we just have more drugs than we know what to do with in a way. So if we can do DARA-RVD, is the next, big kahuna trial, DARA-RVD plus transplant versus DARA-KRD plus transplant, and different variations of maintenance consolidation. So we really could create a large trial to look at that. And I think I'm more impatient, I guess. I want to just know the answer. So maybe it's better to look at things like MRD and depth of response to get those answers.
Yeah, definitely. We all could use more answers more quickly. Let's move on now to the maintenance setting. And there actually are 2 category 1 recommendations. Lenalidomide as a single agent, of course, is what is probably the most widely used standard of care. But we also have data from an exasymib post-transplant study showing that exasymib compared with placebo did prolong progression-free survival. And in certain circumstances, bortezomib with lenalidomide can be considered. And this harkens back a little bit to the Forte trial that we reviewed earlier, which showed that KR was a better maintenance than R alone. In terms of exasymib, these were the data from the Tourmaline MM3 study that did show about a 5-month improvement in the median progression-free survival and a 28% reduction in the risk of progression or death with ICSA versus placebo. And there was good safety and tolerability with no increase in secondary malignancies. And if you've used ICSA, you probably know some of the toxicities, which are just a little bit of GI tox, especially with the first or second doses. And occasionally you can have some thrombocytopenia and a slightly increased risk of infections. Here are some updates on the use of exasymib as a maintenance in both transplant eligible as well as ineligible myeloma patients. The transplant-eligible population was the Tourmaline MM3 study, and the data do show that deepening of response had a substantial effect in lengthening the progression-free survival, and exasymib maintenance did produce a higher rate of deepening and a longer PFS, and that's demonstrated in the curves on the right. And also more recently, we heard about the exasymib MM4 study, which gave ICSA to patients that had not received a stem cell transplant. So these were transplant ineligible patients after an induction therapy, and they did have a substantially longer progression-free survival with no unexpected toxicity, supporting the rationale for single-agent maintenance in this setting with a PI, which is the first study of its kind to do so. The safety summary is shown here. As I mentioned earlier, GI effects like nausea, vomiting, and diarrhea were increased with exasymib, but most of these occur just in the first or second doses in the first cycle, and later on, patients tolerate this quite well. And there is an increase in thrombocytopenia and a small increase in peripheral neuropathy. Importantly, most of these events are low-grade and manageable with supportive therapy and don't require dose reduction. Another question that we're trying to answer right now is whether an antibody with an IMiD could be the next step in post-transplant maintenance. And this is the SWOG S1803 trial, also called the DRAMATIC study. And what we're doing here is taking patients after their first auto transplant and randomizing them to get either len as the standard of care or dara and len as the experimental arm. And then there's a second randomization at 2 years. If people are MRD negative, they get randomized either to continue with their maintenance or to stop maintenance. And the hope is, of course, that the MRD negativity will be so deep that maybe stopping maintenance would be reasonable without an increase in the risk of progression. I think we're excited about that study, and we actually are enrolling ahead of schedule on that trial. And I'd like to thank all of you that are already involved and also encourage those of you who maybe are not to become involved, because we still will be enrolling to the study for several years and we could really use your help. As Dr. Shah mentioned, the more quickly we enroll, the more quickly we'll have answers. So my take-home messages are shown here for maintenance. For the single agent setting, I think lenalidomide is well established, but under some circumstances, exasymib can certainly be considered. And occasionally, I still use thalidomide, predominantly in people who are intolerant of len, such as if they develop severe cytopenias, diarrhea, or rash. When to consider combinations, I usually think about this in high-risk disease. Usually a PI and an IMiD is what I will do. In the short term, we may think about adding daratumumab, and the intermediate term, we may again think about using this in a risk or response-adapted fashion. And I think it will be interesting also to look at bispecifics or BiTEs, as well as CAR T cells as a maintenance or maybe post-transplant consolidation, especially for patients with high risk. Dr. Shah, what are your standards of care for post-transplant maintenance, and when do you use a single agent or a combination?
Yeah, so like you mentioned, almost every study that has ever looked at lenalidomide versus nothing has always shown lenalidomide to be better. And so I always call it the Coca-Cola of maintenance. It always wins, But I think it's so great that we have the Tourmaline 3 study, because it's important to have an option outside of lenalidomide, because some people don't tolerate it, or some people have a reason that they don't want to get it. And so this was actually very important for us to have an alternative. In the absence of using either one of those, I've even used Velcade, for example, which I actually find to be or bortezomib, which I find to be very well tolerated in an every other week fashion for maintenance therapy. But I'm really, really excited to see what the combination maintenance therapy trials will yield. For example, the Dramatic and the Auriga trial. We'll also get some data, a little bit from Cassiopeia in this regard, but maybe possibly incorporating daratumumab. I also was impressed by the Forte data, which does show that carfilzomib and lenalidomide maintenance seems to be better than lenalidomide maintenance alone, although there are a lot of groups in that trial, as you pointed out, so it's not clear if that benefit is really for the group that maybe got KCD or KCD and no transplant. So it's a little bit unclear to me yet whether that's really what we should do for standard risk patients. For high-risk patients, I completely agree. They need more. And it's not that we know that they need more from a prospective trial. It's just that we know that we haven't been doing enough with the standard of care that we have. And so to help these patients have as long of a duration of remission as possible after transplant, I agree with doing something more. Often I do consolidation. If they've gotten VRD in the past, I do consolidation VRD, for example, as demonstrated by the Emory group. Or if they've gotten KRD, then I will do consolidation KRD after transplant as well, for example, by the University of Chicago group. But I totally agree with you that we should be thinking about novel ways to get to these patients, whether it's through immunotherapy, including CAR T or BCMA specific, bispecific therapy, or any of these novel ways of combining so that we can get to the myeloma in another way besides our novel agents, our alkylators, and then using a third way to really get to this high-risk myeloma.
And one thing to mention about the exasymib maintenance study in non-transplant patients is that if I remember the data correctly, it seemed that even folks with ISS3 had a benefit, and that the magnitude of the benefit was actually greater than in ISS1 and 2, which I think is great because ISS3 usually is a higher risk group. And even patients who got CR and VGPR benefited there, which again shows you that even folks that have high quality responses can still benefit from maintenance. And at this point, I'll turn it over to Dr. Shah for her presentation on CAR T and other therapies in the relapsed refractory setting.
Thank you so much, and I'm really excited to talk about my favorite topics, platforms and the role, newer platforms and the role of CAR T therapy for relapsed refractory multiple myeloma. So similar to the lecture you heard from Dr. Orlowski just now, we think about when we need to consider treatment for patients with relapsed and refractory myeloma and some of the prognostic factors. So it's very hard to know exactly when you should start therapy, but there are some sort of clinical rules. So of course, if they have any new CRAB features, any new end organ damage, of course, that's an indication that you should start therapy. If they have a rapid rise in their M protein, or often now we see the light chains, or if you knew that they had high levels of free light chain previously and had subsequent renal presentation or renal dysfunction, if you know that they have high risk cytogenetics or FISH, and they have biochemical progression even in the absence of end organ damage, these would be reasons for you to consider initiating therapy. It's kind of hard sometimes because people will have a biochemical progression and nothing else. And for those patients, you have a little bit of time. If that M protein gets to 0.5, you have a little time to get your data. And I always do like to get, for example, a PET scan and also a bone marrow biopsy. Both of these help us to know the burden of disease that exists. They tell us the urgency, and they can also give us information about clonal evolution, particularly the bone marrow biopsy. So I think these are really important tests to get, not just the lab tests. And then you think about prognostic factors. So what happened to them already? How long has their initial response been? If someone is progressing within a year of their therapy, that is somebody who is clinically, in my view, high risk. Have they had a new abnormality on their bone marrow biopsy, for example, changes in their FISH, cytogenetics? What is their initial ISS or RISS stage? And then factors of the patient. Performance status is very important, and what the goals are of the patient. And this will help you to choose the therapy because you know how they performed before and how they are potentially going to perform with new therapy. And then presence of EMD, for me, that's always a high risk factor because that means the myeloma is smarter than the bone marrow microenvironment and has left it to cause EMD. Definitely circulating plasma cells, I think, is a poor prognostic factor and usually means that we have to be very aggressive with therapy. That being said, there are roles of antibodies in relapsed refractory multiple myeloma, and there are some NCCN recommendations. I want to focus a little bit about antibody therapy now because I think it has really revolutionized what we do in the 1 to 3 prior lines of therapy. And as you can see here, there are preferred regimens as category 1, which include dara, bortezomib, dexamethasone, dara, carfilzomib, dexamethasone, that's a recent one, dara, lenalidomide, dexamethasone, and isatuximab, pomalidomide, dexamethasone. Most of you know that daratumumab is an anti-CD38 antibody, as is isatuximab, and isatuximab most recently got FDA approval a couple of years after daratumumab. I wanted to focus a little bit on the Candor data, which was presented a year ago, but then updated this past ASH, looking at carfilzomib, dexamethasone, dara versus carfilzomib and dexamethasone, KDD versus KD. And as you can see here, originally the data showed a prolongation of PFS in the triplet versus doublet, but this again continued to be true in the updated data. And now we know that the median PFS is 27.8 months. And I think that's really important because you can see how 28.6 months. And you can see how this is very significant and significantly greater than the 15.2 months that was seen in the doublet arm. What does this mean? I think that this means we have really effective therapy for this 1 to 3 prior lines of treatment, and we're now combining our novel therapy. So not just looking at bortezomib and lenalidomide and even pomalidomide, but really looking at things that are even newer. For example, carfilzomib and daratumumab. This data is important also because it shows you what the toxicities are. Their toxicities were fairly manageable, but there were a few more infections in the carfilzomib, daratumumab, dexamethasone arm. You can see here there was a subgroup analysis, and you can see that almost all of the subgroups showed benefit of the triplet arm versus the doublet arm. And I think some of the things that cross one, particularly the age greater than 65, may be related to numbers. But you can see here, even with high-risk cytogenetics, it seemed that the patients who got the triplet arm were able to benefit. A similar study looking at daratumumab combination, now with another novel agent, is daratumumab pomalidomide dex versus pomalidomide dex in relapsed refractory myeloma. This is the Apollo study. I want to point out that this also used subcutaneous daratumumab, which I think is very important for patient experience. Usually, or previously, daratumumab used to be given as a long IV infusion, and many of us remember sending patients for all-day infusions the first time. This has now been changed due to modified due to other randomized trials, and now subcutaneous daratumumab is available, and I think patients really appreciate that. Here you can see subcu dara plus PomDex versus PomDex showed a significant improvement in progression-free survival of 12.4 months versus 6.9 months, and I think this is important because this actually recapitulated nicely, or even outperformed, the data that we had from the phase 2 single-arm data, which was actually what got us to approve, or got the early approval for this combination. And this trial was really nice to confirm that this is a very effective therapy regimen for our patients with relapsed refractory myeloma. I want to switch gears away from antibody therapy and talk about novel agents with novel mechanisms of action. And one of these drugs is called Melfiqin, and it's thought to be a new partner as a combination for relapsed refractory myeloma. As a little bit of a background, this is a first-in-class peptide drug conjugate, or PDC, and this actually targets an aminopeptidase that is more commonly found in myeloma cells, and allows it to rapidly release this alkylating agent, or melphalan, into the tumor cells. So it's a kind of new way to target myeloma cells for this alkylating agent, allowing the drug to quickly pass through the lipophilic barrier and take advantage of the myeloma cells' aminopeptidases to specifically release this melphalan intracellularly. So the original phase 2 Horizon data, which was previously presented this year, showed about a 30% single agent response rate, which I think is probably sort of where you need to be to show that this has activity in relapsed refractory myeloma. At ASH, the Anchor study was presented, and this showed combination of Melfiqin plus either bortezomib and dexamethasone or daratumumab and dexamethasone for relapsed refractory myeloma patients who were refractory to IMiDs and PIs. You can see here that the response rate was actually very nice. It ranged from 60 to 80% depending on if the patients had bortezomib or daratumumab in combination, and some of these responses were very nicely lasting. The median PFS overall, again, 12.9 months, something we saw similar, I think, to the DPD data that we just showed. So this shows us that we are still looking at other drugs that are novel, with novel mechanisms of action, and there are other things beyond just the drugs that we already have approved. And in myeloma, which is an incurable disease, this is a very important thing to have something down the pipeline. Speaking of novel therapies, there is also another drug, which many of you have heard of, called Celinex. This targets XPO1, a nuclear transport, and it's an XPO1 inhibitor, and it induces nuclear retention and activation of tumor suppressor proteins. And this allows tumors to actually have internal suppressive action so that these cells will die. So this is a very novel mechanism of action, and one that we haven't seen in myeloma cells, and that's why it's one of the things that is a new way of attacking myeloma cells. And as I just mentioned, these are the things that we need more in our therapy regimens because we already have existing mechanisms of action, and we want to have something new that we can maybe add and take advantage of another weakness in a myeloma cell. So the original data, which showed the efficacy of selinexor, showed about a 30% response rate for patients with selinexor single agent and dexamethasone. And this is what ultimately allowed for selinexor to be approved for selinexor and dexamethasone in pentarefractory patients. But what has been very interesting about selinexor is that it seems to be better tolerated and actually efficacious in combinations. So we know this about myeloma drugs. Usually they have to show single agent activity, but then they have to have a pathway forward. And I think the pathway forward for selinexor is in combination. And one of the examples of that is the Boston trial, which looked at selinexor, bortezomib, and dexamethasone versus bortezomib and dexamethasone. And something very interesting about this trial is that the experimental arm, which was the triple arm, had bortezomib as a weekly dosing versus the control arm, which had twice weekly dosing. I think that's important because this actually is a pretty user-friendly regimen since selinexor is oral and the bortezomib was weekly. As you can see here, there was a nice difference in PFS, almost 14 months in the experimental arm for SVD versus VD. And just talking a little bit about the safety, you can see that some of the things that we know to be true about selinexor, which include thrombocytopenia and fatigue, were seen a little bit more, definitely thrombocytopenia in the experimental arm versus the doublet arm. One thing that we did notice in this particular study is that the known side effects, which include nausea and fatigue, seem to be more controlled because of the weekly selinexor dosing and not as bad as we had seen in the original data, the STOMP data, where the STORM trial, where you saw significant nausea with twice weekly dosing of selinexor. And I think this is one of the things that we learn as we go along with myeloma drugs, that as you get more experience with them, you can see how dosing modifications can make them more tolerable, and maybe some combinations can make them more effective, and sort of trying to optimize the best way to use these novel drugs. So some take-home points on new platforms in relapsed or refractory multiple myeloma. If you focus on the CD38 and other antibody platforms, you can see that daratumumab combinations with the second-generation PI or IMiD are very effective in relapsed refractory multiple myeloma. The safety profile we didn't talk too much about, but is appropriate. There are some increased infections when you combine these drugs, and something you have to know and watch out for, particularly in your older patient populations. The subgroup analysis, I think, especially for the Candor trial, is reassuring that in various subgroups, this regimen seems to be effective with a very nice PFS. And isatuximab, which is the other CD38 antibody, also has promising data with carfilzomib, which is the IKEMA study presented at EHA and updated at ASH, and pomalidomide, as I showed you, the ICARIA study, which was recently presented as well. Thinking about regimens exploiting novel mechanisms of actions, we talked about melflufen, which is a new twist on an old idea. We know that myeloma cells are very exquisitely sensitive to alkylators, and this really begs to the question of, is there a way to give melphalan or melflufen in a more consolidated way like we do with transplant? I think that's something that might be thought of in the future, but it is a new twist on an old idea, and it appears to be effective, especially in combination. Selinexor, which is a drug that has shown single agent activity with the novel mechanism of action, is more effective and less toxic as a combination agent, as we saw in the Boston trial. Very interestingly, these data with these combinations, melflufen or with selinexor in combination, the PFS data is rivaling that with the DPD. So I think that these are things that we shouldn't just say, okay, they're new, we're not used to them, we don't want to use them, but actually these drugs can be effective in combination. So Dr. Orlasky, I want to ask you, what's your preferred regimen for the first progression for a myeloma patient?
Well, I think that, of course, it depends a little bit, as you pointed out, on the prognostic and clinical features. But assuming that folks are progressing on lenalidomide maintenance, I think the next option would have to be either a combination based on PomDex, and you could do Elo-PomDex, you could do Dara-PomDex, or you could even do isatuximab-PomDex. Or you could do something based on carfilzomib and dexamethasone. And there again, Dara-CarDex, as you showed from the Candor data, would be really attractive. And I think soon we'll be able to do isatuximab with PomDex as well, and isatuximab with CarDex.
Yeah, I think that we have a nice array of options, and I think, in my next slide I want to talk about how do we think this is going to be affected by what we talked about in the first part of the talk, which is it's unclear to me how the implementation of the CD38 therapy for relapsed patients is going to be impacted by Dara in the first line. So what do you think about that?
I think a lot will depend on whether Dara is then continued as a maintenance, because if you do, for example, VRD Dara as an induction and then do transplant and then do Len as a maintenance, you could then go back to a Dara containing combo or an ISA containing combo when they progress. My bias, though, is that if Len and Dara is used as the maintenance and you're progressing on a Dara-containing combo, then probably continuing Dara with a different partner will not be as good, and then something like a carfilzomib Pomdex would be probably very reasonable. I also think, by the way, to keep in mind that for the T1114 patients, venetoclax and venetoclax-based combinations should be something to consider. And while we have often waited to do those until later lines of therapy, I think that we have some data to consider doing them early, even as a second line, for example, in combination with bortezomib for the 1114 folks.
Yeah, I think that's a really good point, and we're all excited to see the first biomarker-driven therapy. So I actually do use venetoclax earlier than I used to for 1114s as well. I think one of the things that's really made me think about what I use in the second line is patient experience and quality of life, and I think that daratumumab being available subcutaneous is a big deal, and that's why a lot of times I do like to use Dara-Pomdex because it's kind of user-friendly. Do you agree with that?
I do agree with that. I think sequencing, as you've got in your next panel, is going to be a very important question, because the great news is that we've got all of these novel therapies that are coming, but we don't quite yet know exactly what order they should be used in.
Yeah, and that's kind of how I feel. I feel like there's a lot of novel therapies. We're talking about CD38. That's already moving a little bit more forward. We're going to talk a little bit more about BCMA, and I could see in the future BCMA being something that moves forward as well. And then what's going to happen? We still need drugs that work. Alkylators. We still need drugs with novel mechanism of action, for example, Celinex. And I think, and I'd like to hear your opinion, I kind of think that maybe it might be a post-BCMA population where we need to understand where these drugs work. What do you think?
Well, I could definitely see the BCMA targeted therapies being used as a second line very soon. We did present some data at ASH that suggested that you could use an isatuximab-based combination after a prior Dara-containing combination. But realistically, I think that what will happen in the future is that Dara-based combos will be first line, and then especially, as we mentioned earlier, in people who are progressing on a Dara-based maintenance, coming in with a BCMA targeted therapy. And I think we don't yet know whether that should be an ADC or a bispecific or a CAR T-cell, but I could see the BCMA targeted therapies coming into second line. And then I think we're going to need to look at, can we reuse a BCMA targeted therapy in third line if they've progressed on a BCMA therapy second line, or do we need to go with a different approach targeting a different antigen? Or is that the space for drugs like selinexor and melflufen, where you will maybe not have as much benefit from an immunotherapy and you need to come in with a more cytotoxic mechanism-based approach?
Yeah, it's great to have different mechanisms of action and effective drugs in each of these, and to be able to see combination data. So that's been really exciting. I want to move on to another topic very close to my heart, is cellular therapy, and why BCMA CAR T is the next leap forward. And of course, this is very pertinent to our audience today. I'm very interested in cellular therapy. As many of you know, BCMA has been the choice target for CAR T-cell therapy for multiple myeloma patients. And the reason for this this is that BCMA is uniformly expressed on almost all plasma cells. So it's an antigen that's there. And it seems to be involved with some proliferation or survival of the myeloma cells, but it's almost less important what its function is and more important of where it is. And that is that it's on the surface of myeloma cells, on the surface of plasma cells, but it's not on the surface of most other cells in the body, which makes it an ideal target for something effective like cellular therapy. The first BCMA cellular therapy, I would say the cellular therapy trial that made the biggest splash initially was the BB2121 initial phase 1 data. Here you can see the design where patients with relapsed refractory myeloma were enrolled and received after apheresis and during cell production LD chemo with fludarabine and Cytoxan, and then eventually got their BB2121 cells infused, and after which they were monitored for safety and efficacy. Initially, this data was very promising, published in the New England Journal. They had an overall response rate in their highest groups of 100%, but if you look at all of their groups, it was 75%. This data was presented most recently at ASH. What struck me about this updated data, first of all, it's one of the longest follow-up data we have of US-based BCMA CAR T data, although it was a phase 1 trial, so you have to keep that in mind. Secondly, their overall survival, the median overall survival was on the order of 34 months, which I thought was very interesting given that this was a very heavily pretreated patient population and not that long ago. So I thought that was encouraging to say that there is life after CAR T, even though most patients had progressed between a little before a year and a year. You can see that there are other options for patients after CAR T. But very interesting, you can see here that the duration of response by the target dose looked to be important, where you can see the duration of response at the 450 dose, and I highlight that because that's probably the dose that's going to go forward for FDA approval, although this was a slightly different manufacturing process, was 10 months, and the higher doses seem to have a better duration of response, so dose does matter. Very interestingly, you can see that this is just phase 1 data, and before a couple of years ago, we really didn't see phase 1 late-stage data like this for multiple myeloma, and because of that, the phase 2 KARMA study was then conducted. This was a trial of 128 patients who actually got infused with BB2121. This was a phase 2 trial, but it had some dose variations. Some of the patients got lower doses, for example, 150 million, some got 300 million, and some got 450 million. Again, 450 million is likely going to be the going forward dose. So I want to focus on that data. This was updated at ASCO this past year, and you can see that for this pivotal phase 2 study, the overall response rate was 73%. But again, I want to point you to the 450 dose, where the overall response rate there was 82%. We know that these patients actually did similarly to the phase 1 data, where the median PFS in that 450 dose was around 1 year. So this was nice to affirm or confirm the results of the phase 1 data, and I think hopefully are going to lead to approval of this novel CAR T-cell therapy, the first one of its kind for myeloma. I think one of the things that I always think about is that this is a therapy that can give patients a year of life without additional therapy. And that seems like a small amount of time, but it is a large chunk amount of time for myeloma patients. So I do think that it's important to consider quality of life aspects for this. Looking at toxicities, we always do worry about CRS and neurotoxicity. And I think it's important to see here that, most people did have CRS. The rate of CRS, I believe, was over 80%. But the CRS tended to be grade 1 and grade 2, very manageable, generally with tocilizumab, rarely with steroids. And I don't think there were any grade 3 or very few grade 3 or 4 CRS events. So I think it's important as we get more experience with these CAR T cells that we do expect CRS and we are going to have to monitor the patients, but that we don't have to be afraid of it and it is manageable. I want to turn now to CARTITUDE-1, which is cilta-cel, as it's going to be called. This is the Jansen CAR T-cell product against BCMA. Very similar to BB21, but also a little different. As you can see here, the extracellular binding domains of this product actually bind to 2 different epitopes of the BCMA molecule on the myeloma cell. I'm not sure what that means as far as changes, but it does seem to have some different kinetics than the BB2121 data. This data was initially presented last year and most recently updated by Dr. Maduri at ASH, and you can see a very impressive 97% overall response rate in this phase 2 data. This trial was a larger trial, almost 100 patients, around 100 patients, which was set to confirm the study, the Legend trial, which was run in China. This was a US trial. And so that data from Legend had been very impressive, and we wanted to see if we could recapitulate that data here in the US. And indeed, 97% of patients responded. And look at the depth of response. 93% of patients had a VGPR or better. If you look at the MRD data, also very impressive data. You can see here that you have 54% MRD negative, but it seemed to be that the patients that were stringent CR and MRD negative, also very impressive data here. Also nice data to see that the times of responses were pretty quick. The patients were having their first response within 1 month, and a lot of people at the 10 to the minus 5 achieved MRD negativity within 1 month. So I think this is a quickly very active therapy and one that is definitely going to be on the watch. Although this is sort of the second CAR T-cell to be developed, it'll be very quickly on the tails of the BB2121 because of its efficacy. We don't yet have the long-term data. What we do know is that at 12 months, 77% of patients were still in their response, which, as we know, was generally VGPR or better. So it seems that the data is going to outperform the BB2121 data, but it's a little premature to say since the follow-up has not been as long as the BB2121 data yet. I do want to point out, again, most patients do have CRS here, 92%, although I will say that the difference of the CRS is that the timing of it is a little different. 7 days median onset, and that ranged from day 1 to 12. It tended to be earlier in the ide-cel, so that kind of changes some things you would think about if you were planning your patient's course. It tended to be low-grade CRS. As far as ICANS go, they had some patients have ICANS, but they also had neurotoxicity that was non-ICANS related, and this tended to be a little bit less clear of a neurotoxicity, but that was not immune effector associated, and some people actually did succumb to this neurotoxicity late in the course. So I think we need to know a little bit more about those details, but in general, the CRS was low grade, as was the neurotoxicity, and I feel comfortable with this product, and certainly is very effective. There are other CAR T-cell therapies that are being explored. The LumaCAR data was very impressive. This again is a CAR T-cell product originally developed in China and now being explored in the United States. 94% overall response rate. The numbers are small still, but there is a lot of promise for this particular CAR T-cell data. And then there were other different CAR Ts, and I'm just highlighting one. This is the Poseido CAR T, which uses a transposon-based CAR T generation, so not retrovirus or lentivirus. And you can see here that in their new manufacturing system, they had actually a very nice response rate and very low CRS. I think this is one of the CAR T cells that has probably the lower end of CRS percentage. So this is one of those that we might be able to consider in the future for outpatient therapy, but I think we need longer follow-up data to see how durable these responses will be. So some take-home points from the BCMA CAR T-cell studies. We love to compare our apples and oranges. The ide-cel data shows an overall response rate of 73% for all cohorts, 82% for the 450 million dose level. The PFS, again, 8.8 months for all of the patients and a year for the patients at the 450 level. The CRS, probably going to happen, over 80% of people had it, but it tends to be early in the course in grade 1 and 2. And there was some quality of life data presented at ASH that suggests that patients who get ide-cel actually improve quality of life. And it does support actually implementing this, even though there's a lot of upfront sort of investment from the patient. Similarly, the cilta-cel Jansen CAR T-cell, very effective and very impressive overall response rate of 97% with 93% VGPR or better. CRS, again, did happen in most patients. The timing is a little more variable than ide-cel, but definitely able to be controlled. There was some non-ICANS neurotoxicity that we probably need some details on. And at the 12-month mark, 77% of people are still in response. And I think that's just a really impressive piece of data for a one-time treatment, that they don't have to go to the chemotherapy suite every week. And these are very heavily pretreated patients, median of 5 and 6 prior lines. So this is a tough patient population. So thinking about making choices for BCMA CAR T, we think about who's a CAR T-cell candidate. And I think probably it's going to be patients with 3 prior lines or 3 prior treatments, and those semantics can matter when you're thinking about the FDA label. We think about fit patients. I always say, if your patients can handle 3 liters of fluid, I think they can do CAR T therapy. And it's true, actually, we've had a lot of patients that are older and that maybe didn't want to get a transplant in the past. They actually have gone on to CAR T and they've done fine. I think this is okay for older patients. If you're thinking about tactics for CAR T safety, so I think that we learned a lot about our CAR T experience from the CD19 experience. So I say sometimes it's nice to be second at the table because we know. And we do know that tocilizumab usually takes care of most of the CRS, but if you have to go to steroids, you have to do it. We always say hashtag no toci shame. There's no shame in giving toci. We just had an analysis this past ASH to show that early tocilizumab within 12 hours of the first fever versus later tocilizumab did not change outcomes. So there's no reason to subject the patient to additional toxicity if you're really worried about CRS. So Dr. Orlowski, I wanted to ask you, what do you think about all this CAR T data? I mean, are you as excited as I am?
Well, I think these are the best data that we've ever seen in the relapsed refractory setting with respect to the depth of response, with respect to the duration of response, and these are the toughest patients that we've ever treated, because compared to 5 years ago, for example, they've had so much better therapy, and the myeloma is therefore that much more refractory than it used to be. So you can't help but be excited. And I think what you touched on in terms of patients being able to be off of therapy, for some of them, this is the first time they've not been getting some kind of regular treatment for years and years, and they really enjoy that and have a great quality of life.
Yeah, I think that point cannot be overstated. So we are really excited about BCMA CAR T therapy. And in the last few minutes, I just want to touch on what was a big splash at this ASH, which is the bispecific antibodies and what the role is of bispecific antibodies. As you know, bispecific antibodies target both the tumor antigen and also CD3 to sort of bring together the tumor cells and the effector cells. I call them the eHarmony of immunotherapy. And this year, we had a really nice splash of BCMA and other bispecific antibodies. And one thing that we learned was that BCMA, it's not just about BCMA. There are other targets. And in this case, for example, GPRC5D, the antibody, the bispecific antibody, also known as talquetamab, was presented. And I just was really impressed with this data. Overall response rate of 69% at their 405 dose. Really refractory patients. Some of them had BCMA targeted therapy. Dr. Orlowski, what did you think about this bispecific data?
I think the exciting part of this is the ability to target a different antigen. One of the things we're all worried about is the possibility that if you have a BCMA targeted therapy, that the most obvious mechanism of resistance would be some measure of antigen loss. For CAR T cells, that doesn't seem to be a big problem, but I have a feeling that when we use more of the ADC and bispecifics, because there is constant presence of selective pressure against BCMA with those, whereas the CAR T cell, the T cells don't hang around for as long as we would actually prefer that they do. But my feeling is that we will get more BCMA negative disease after the ADC and bispecifics, in which case going after a different target makes the greatest sense. So I think that's the exciting thing. It's not just about BCMA anymore.
Yeah, and to that end, there's also another antibody or bispecific that's being developed. This is cevostamab against FcRH5. Similarly, I was also very impressed by this. Again, phase 1 data, 53% overall response rate in the patients receiving active doses. I think this 60 is the new 30. You know, we used to say that 30, and I even said it, 30% was sort of your benchmark for trying to get something in phase 1, showing that it has efficacy. And now we're getting drugs at the 60% mark. So I think we're getting a little spoiled, as I always call myself a millennial. We don't see data like this usually in this late line. So this is really exciting. I want to thank everybody for their time and attention today.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/ATX860. This activity is supported through educational grants from Adaptive Biotechnologies, Bristol Myers Squibb, Jansen Pharmaceuticals Incorporated, administered by Jansen Scientific Affairs LLC, Karyopharm Therapeutics, Oncopeptides Incorporated, and Takeda Oncology.